Good afternoon, and thank you for joining us for today's hybrid program, History at High Noon, the intersection of history and medicine. A few housekeeping notes for today. Please hold your questions until the end of the talk, and our speaker will ask or answer as many of your questions as time allows at the end of the presentation. So it's my honor to introduce and welcome our speaker this afternoon, Michael Soboeiro, MD, who's the Associate Program Director of WakeMed Internal Medicine. Soboeiro is a general internist with 29 years of experience practicing medicine, teaching, and doing medical research. He has worked at WakeMed for 9.5 years. He currently heads the outpatient teaching program of WakeMed's internal medicine residency program. Soboeiro was named one of North Carolina's top doctors by Business North Carolina in 2021 and 2022. Please join me in welcoming him.
Thank you very much. My name is Mike Soboeiro. I'm a general internist, as Stacy said. I'm real happy to be here. My interest in this was developed because my dad was a U.S. history teacher. And when I started in medicine, he started talking to me about how medicine and healthcare had affected history over thousands of years. And he had a book called Plagues and People he would talk to me about. And so I give a lot of talks. Most of those talks are medical, but I always wanted to talk about how history and medicine interact. And so I came up with this lecture to give to my residents. And I thought, wow, it would be fun to give it to a non-medical population, to a lay population, and see what you all thought of it. And so that my caveat too is that I am not a historian. And some of you may know more about the history part of this than I do. And at the end, I welcome your questions, your comments, your feedback. So let's talk about the intersection of history and medicine. I'm going to start with a quote by George Santayana. George Santayana was a philosopher back at the turn of the 20th century. He actually worked at Harvard. And I think this was his most famous quote: "Those who do not learn from history are doomed to repeat it." And there's a couple of permutations about how that was said, but the basic meaning, is, and I think people in history believe this, but I think people in medicine should take this more seriously. We don't spend a lot of time in medicine talking about the history of medicine. We talk a lot about studies and trials, but I think we should think about our history, because I think we can learn a lot from our history. And I think we need to be careful that we learn from our history so we don't repeat it. We don't repeat the bad parts. So I'm going to talk about a couple of cases, and these cases are the medical care of U.S. presidents. And so this is case one. Case one is a 67-year-old male with a history of malaria 4 times, tuberculosis, smallpox, diphtheria, and depression, who suddenly presents with mild hoarseness that quickly progressed to fever, throat pain, shortness of breath, and difficulty swallowing over 12 to 16 hours. Basically, this gentleman was in good health. He was riding around his farm one morning, and all of a sudden he started to get this hoarseness and very rapidly progressed to the symptoms noted above. No other past medical history that's pertinent. And this is, by the way, this is how we present cases in medicine. We kind of go through aspects of the history. So that's how I'm going to present it to you. Social history, not a smoker, moderate user of alcohol, very active, very socially prominent. Family history, had a brother with chronic tuberculosis. On physical examination, at the time that he was presented with this illness, by the time his physicians came to examine him, he had a fever. He was alert. He appeared uncomfortable. He was walking around his room very nervously, unable to swallow, some difficulty breathing and speaking. So I'll just stop for a second and ask, does anybody know who this is off the bat? Anybody in the audience here? No, it wasn't Lincoln. George Washington, absolutely. This is George Washington, case of George Washington. Okay. So in medicine, we try to come up with what's called a differential diagnosis. I ask my residents to tell me what are the top possibilities for this case. And this was the differential diagnosis in 1799, come up with by the physicians who were taking care of Washington. And so these diagnoses are a little different than what we come up with today. So one was what they called at the time inflammatory quinsy, which is basically a tonsillar abscess, an abscess or an infection in one of the tonsils. Probably doesn't fit this case too well because that would typically be unilateral and it wouldn't really affect swallowing to the extent this would, one would not expect. The next one was what was called at the time stridula suffocatus, which is basically tracheitis. And tracheitis, so, you know, many of you have heard of croup. Croup is essentially tracheal inflammation, and we think of that as a child's disease because it has much greater effect on children because children have smaller tracheas. And so a little bit of inflammation in children can cause some serious breathing issues. We don't typically see a lot of croup in adults, which is why this probably wasn't the diagnosis for Washington. What they called laryngia at the time, laryngitis, another possibility. Laryngitis isn't usually this bad. Doesn't usually cause this level of swallowing difficulty and breathing difficulty. You know, most people here have probably had laryngitis and pretty mild stuff just affects your voice. And then finally, what they called Sinank tracheitis or acute bacterial epiglottitis. That's what we'd call it today. And that's probably what Washington had. The epiglottis is the little flap of tissue that goes over your trachea when you eat so that what you eat doesn't go down the wrong way, doesn't go down into your trachea and into your pulmonary system. And the epiglottis can get inflamed and infected. And when it does, and it gets swollen, it can affect the airway. And so that's probably what Washington had, which was bacterial epiglottitis. So some of you may have been to Mount Vernon and seen about this or read about this. When Washington was ill, there were 3 physicians in attendance. And the first thing they did, which is what they did at the time, is they bloodlet. So they took out blood. They phlebotomized him. And they removed basically 2.5 liters of blood over 12 hours. So that was about 40% of his blood volume. That's a huge amount of blood to remove from anybody. Much less someone in their 60s who might have other illness. We would shudder to do anything like that today. I mean, we don't bloodlet, but if someone lost half their blood volume, we would be quite concerned. Other things that they did for Washington, they gave him a combination of oral molasses, vinegar, and butter, which led to choking. And a lot of these oral treatments, I mean, this gentleman was having trouble swallowing. He had an inflamed epiglottis. We wouldn't give him anything orally, but they tried these oral things that typically led to problems. They gave him some oral sage tea, which caused near suffocation. They gave him calomel, which is mercury. It's basically a cathartic and makes one's bowels move. And mercury is a pretty toxic substance, probably no positive effect here. Antimony, an emetic, make one throw up. No real benefit here. Blister of cantharides. I was interested to learn about this. This was blistering to the skin that was used up until about the 1960s. It was something that could be used to remove warts or remove skin lesions. Not sure why blistering his throat would have anything to do with what was going on inside, but this is what they tried for George Washington. So that we talked about, there were 3 physicians present. The youngest one was Elisha Dick, and he was 37, and he argued that bloodletting was weakening Washington and the bloodletting should stop. He was overruled by the older 2 physicians. The one we know about was James Craik, and apparently he had been Washington's physician for the longest, and he was the one who was calling the shots here. And he overruled Dr. Dick and said, nope, we need to continue with the bloodletting. After the 4th bloodletting, swallowing seemed to improve a little bit, but an hour later, his condition deteriorated. He got worse. They did more blistering to his feet, his arm, and his legs. They put wheat bran poultices on his neck. Dick then argued for tracheotomy. So tracheotomy is putting a hole in the trachea to make it easier to breathe. And we do tracheotomies all the time in emergencies when people have upper airway obstruction and cannot breathe. And a tracheotomy would certainly have allowed Washington to breathe. Dr. Dick argued to do a tracheotomy, but he was vetoed by Dr. Craig. And unfortunately, General Washington died 2 hours later. There was a fourth physician, William Thornton, who showed up the next morning, and he suggested thawing Washington's body. Washington had been dead now for over 12 hours. He suggested thawing the body, doing a tracheotomy, and infusing lamb's blood, which was pretty aggressive. Fortunately, this was refused by Martha Washington, as General Washington had died, and I think she felt it better to leave well enough alone. This is a picture you may have seen. I've not seen where the people in the picture are identified, but you know, the two with the concerned looks, I guess I think of them as the older physicians thinking, what have I done here? But who knows? Who knows? So let's talk a little bit about bloodletting. Bloodletting originated in ancient Egypt and Greece. The idea at the time was that all illness stemmed from an overabundance of blood. And then in about 100 AD, Galen, who was the sort of physician expert of the time, came up with this theory that good health was a balance of 4 humors. And those humors were blood, phlegm, yellow bile, and black bile, and that the humors needed to be balanced. And the one, of course, they could balance the easiest was blood. And that's really where, you know, bloodletting kind of took force as an important part of medical care for the next 1700 years. And one of the things I'll talk a little bit more about, you know, Galen's ideas went unchallenged in a lot of cases for over 1,000 years. And the main reason for that is that medicine wasn't moving forward during that period. And the main reason for that is that the Catholic Church prevented anyone from doing necropsies, from essentially working on cadavers, on human cadavers. And since the Catholic Church had this prohibition, there was no real way to move forward with anatomy. Physicians would dissect, you know, dogs or monkeys, but they weren't humans. And so this really prevented the forward movement of medicine. And that's why I think this 4 humors persisted for as long as it did, and bloodletting persisted for as long as it did. There was some skepticism of bloodletting in the late 18th century. Washington's physicians reasoned that since bloodletting was causing vasoconstriction, it would decrease tracheal inflammation. So the idea there is that if you remove blood vessels will clamp down, right? Because they're trying to keep the blood pressure stable. And when those blood vessels clamp down, fewer inflammatory factors will be released. That's basically true, but you know, the good analogy for that would be, you know, using a sledgehammer to crack a nut. You know, you're using this, you know, you're taking somebody's blood out just so that you can get a little bit of vasoconstriction in the trachea. It's just way too much for what you're trying to accomplish. And bloodletting was finally discredited by the late 1800s. And this is a picture of bloodletting that occurred. This is mid 19th century. But you know, this persisted as basically one of the main things that doctors did, and barbers were actually the ones who did the bloodletting. That's why they had the poles with the red on them, because of the bloodletting. Now, what could have helped Washington? What might have worked? Certainly antibiotics might have helped. If he had acute bacterial epiglottitis, it would have been nice to get some antibiotics going. Unfortunately, you know, there were no antibiotics for more than 100 years after Washington's death. The first antibiotic was salvarsan in 1910, and then real antibiotics, you know, penicillin in 1928. Intubation is putting in a breathing tube through the mouth. And intubation certainly would have helped. There was some intubation starting in 1788 in drowning victims. I think that was mostly in Europe. Wasn't routinely done until 1885. Tracheotomy, as I talked about before, cutting a hole in the trachea, was first described in 2000 BC and had been done, here and there over time. There was a very successful case by a physician in Italy in 1543. But, they didn't have the internet at the time, and they didn't, medical information wasn't disseminated the same. So these weren't things that, that were taken on and done routinely. So tracheotomy was certainly done. And as I mentioned, Dr. Dick suggested tracheotomy. And if they just could have gotten Washington through, a couple of hours with a tracheotomy, he may well have made it through completely. Of course, taking out half his blood volume probably didn't help at all either. Tracheostomy is opening a tracheotomy and then putting a tube in. And that was first done in the early 19th century in France for diphtheria. And then in the mid-19th century, they started putting in cuffed tracheostomy tubes. So that's basically what we will do today for airway obstruction. We'll open a tracheotomy, we'll put a tube in, and then we'll put a cuff inside. So the cuff holds it inside, stable. And then you have, patient breathes through the tracheostomy until you fix the upper airway obstruction. And that certainly would have worked. And then, what I didn't put down here is there's pretty good evidence that if they just hadn't bled half of Washington's blood volume, he may have been able to survive this without any of those things. But there was a physician there at the time who was saying, hey, let's do a tracheotomy. And it would have been nice to see if what had happened if that had been done. Now, I have here implications of Washington's death. And here's my caveat again. This is the history part. And this is my conjecture. So this is some thoughts I have about what would have happened if Washington had lived a little longer. Washington was an old man at his death, but still revered as America's most important citizen. He had 700 dinner guests at Mount Vernon in 1798 alone. He was outspoken against regionalism and factionalism. One thing he said is, your union ought to be considered as a main prop of your liberty, and the love of the one ought to endear you to the preservation of the other. So, I think Washington would have continued to be a very strong advocate for the union as important to each person's freedom and liberty. Washington felt that when Americans voted according to party loyalty, rather than the common interest of the nation, he feared it would foster a spirit of revenge and enable the rise of cunning, ambitious, and unprincipled men who would usurp for themselves the reins of government, destroying afterward the very engines which have lifted them to unjust dominion. And I'll leave that one right there about today's political situation. Would an outspoken Washington who lived a few more years been able to prevent the factionalism and partisanship that created our current political climate? And remember, the election of 1800 is where a lot of that partisanship started. And so Washington died a year before that. Could Washington's presence have changed some of that? Interesting to think about. Case 2. We have a 53-year-old male with a history of polio who presents to his physician for a routine physical, generally healthy, takes no medications, heavy smoker, moderate alcohol use, blood pressure 136/78. And for those without a medical bent, we're going to talk about blood pressure here. Our goal right now in medicine is to keep people's blood pressure under 130/80. Under 130/80 is optimal. So this gentleman who presented at his initial visit was 136/78, so a little bit borderline. He came back 2 years later for another physical, no change in his health status, felt fine, but his blood pressure was 162/98. We would take that pretty seriously. We would probably start medication for that if it was persistent. But in this case, years ago, nothing was done. He came back later, 4 years later, again, no change in health status. Now his blood pressure is 188/105. We'd take this one really seriously. Like, I'd see that person back in a week to make sure their blood pressure was better. Comes in again 3 years later. Now he's got some problems. He's been having some afternoon headaches, some morning sleepiness. He had an episode of passing out. Okay, he passed out completely, along with some shortness of breath. Blood pressure at the time was 186 over 108. He did have some testing. So his EKG showed enlargement of his heart. That's not usually a good thing. It means the heart's working too hard. It means it's pumping hard against something. So heart enlargement is meaningful. He had protein in his urine, what we call proteinuria. Usually what that means is the kidneys are under stress. So the heart's the heart in this case is under stress. The kidneys are under stress. The chest x-ray also shows heart enlargement. There's fluid in the lungs, which typically means fluid is backing up. It's backing up from the heart because the heart's not working well. So he sees a cardiologist. And what we know is digitalis is started. So, I'll start out by saying that any patient who presented with stuff like this would get immediate care, would probably be admitted to the hospital today. We don't know all the details of what happened. We do know he didn't get admitted to the hospital. And obviously the armamentarium of things that were available was much less than today. Digitalis is a medication. It comes from the foxglove plant. It's been around for 200 years. And what digitalis does is it makes the heart pump a little harder. It increases the force of contraction. So this is helpful in this case because it helps get fluid moving forward rather than backward. But what's missing here is relieving the stress that's on the heart, the stress that's on the kidneys. Okay. So 1 month later, our gentleman is feeling better. His shortness of breath is better, but look at his blood pressure. I mean, now we're talking about serious 210 over 110. Anybody know who this is? FDR. This is FDR, right? Okay, so he's diagnosed at the time with congestive heart failure. Congestive heart failure essentially means what I talked about earlier. Fluid is backing up into the lungs because the heart's not moving it forward. The digitalis is continued. The cardiologist is now following his blood pressure closely, but he's not doing anything about it. 2 months later, blood pressure is 226 over 118. This is blood pressure that's almost 100 points higher than what we're looking for. Very dangerous effect on the blood vessels, effect on the heart, effect on the kidney function. 3 months later, our gentleman has an episode of severe chest pain radiating to his arms. What we know is that his EKG and his white blood cell count, which really has very little to do with this, white blood cell count is a marker of inflammation or infection, but the EKG and the white blood cell count show no unusual abnormalities. He's not admitted to the hospital, unclear what, if anything, is done. His blood pressure is recorded at 220 over 110. 6 months after that, his blood pressure is 260 over 150. I may have seen a blood pressure like that once or twice in my 30-year medical career. He has fatigue, he has weight loss, he's starting to look haggard. And then 2 months later, he is sitting at his desk, he has a severe headache, he passes out, his blood pressure is taken 300 over 190, and he's pronounced dead. And of course, this is FDR in 1939. So this isn't FDR as a young man. This is 6 years before his death. And this is well into this period of having this very high blood pressure. His personal physician, Ross McIntyre, stated that the cerebral hemorrhage, quote, came out of the clear blue sky. The White House press secretary said, the president was given a thorough exam by 7 or 8 physicians, including the most eminent in the country, and was pronounced organically sound in every way. This is fantasy. I mean, and I'll, we'll go look at the picture. This is FDR at Yalta. This is 2 months before he died. I mean, this is not a gentleman who's in the peak of health. There can't be any physician who could look at this guy and say this guy was in the peak of health. And if you read about Yalta at the time, he was confused, he was tired. This is made up, that 7 or 8 physicians thought he was organically sound in every way. He didn't have an autopsy. The embalmers noted that the arteries were so severely clogged with plaque that the embalming pump strained and stopped. Okay, how bad off his cardiovascular disease must have been for this to be the case. And amazingly, all of his medical records were lost at the time of his death. So we have no idea, any of the details. FDR had what was called at the time malignant hypertension. It's likely renovascular. So cases like this of really bad high blood pressure usually start in the kidneys. And it's a vicious cycle where the hormone balance in the kidneys is such that the blood pressure goes up. The blood pressure then exerts more pressure on the kidneys. The kidneys get worse and make the blood pressure worse. And it's a vicious cycle that leads to very, very high blood pressure. We would call this hypertensive crisis today. Basically, what hypertensive crisis means is blood pressure high enough to cause end organ damage. When we see end organ damage, that denotes the seriousness of blood pressure. And as I said, there a couple years before he died, FDR had heart failure, had kidney problems. So he had hypertensive crisis for years that went untreated. In 1945, hypertension was not considered a disease of major clinical consequence. It was viewed as essential to force blood through narrowed arteries to target organs. And we still call it essential hypertension today. What we mean by essential hypertension is that there's no obvious cause of it, but this is why we came up with the term essential. Paul Dudley White, who was the preeminent cardiologist in the country, in 1931 said, "Hypertension may be an important compensatory mechanism which should not be tampered with, even were it certain that we could control it." And Dr. White was absolutely, positively 100% wrong, but that's what they believed. In 1939, the mean survival with malignant hypertension was 10.5 months. The first high blood pressure agents started in the early 1950s. Diuretics were the first agents. We still use those today. In the 1960s, there were better agents. 5-year survival with malignant hypertension was 50 to 60%. By the 1990s, with better medications and the use of dialysis, the survival rate with malignant hypertension approached that of patients with uncomplicated primary hypertension who didn't have end organ damage, which really marked the fact that we were much better at treating this. And currently, the 5-year survival is 75 to 85%. So, if you have hypertensive crisis where you have end organ damage, we really can get the blood pressure down, and in many cases, we can reverse the end organ damage. Historical context of FDR's illness. So I got this from my reading. FDR was severely ill when he, Churchill, and Stalin negotiated the fate of Eastern Europe at Yalta in February of 1945. A 1989 analysis discussed the deadly hiatus in US leadership from when FDR's health and judgment began to fail to the point at which Truman awoke to Stalin's intentions. That writer believed the hiatus led to Yalta and Potsdam, the betrayal of the Poles, the imposition of communist governments in Eastern Europe, the Czech coup, and the loss of China and the invasion of South Korea. So we can debate all of that, but basically, if FDR had lived, maybe the 20th century would have gone a little bit differently. Interesting to contemplate. Okay, the last case we're going to talk about is a 64-year-old male with no prior cardiac history, had a 150 pack year smoking history. So if you're not familiar with that terminology, what we do in medicine is we multiply the packs per day times the number of years. So if you're a 2-pack a day smoker for 40 years, then you have an 80 pack year history. So 150 pack years is a lot of smoking. So 150 pack year smoking history. Presented with indigestion while playing golf. So he was away from home at the time on a golf course in Denver, Colorado, had some indigestion, said he thought it was a bad burger he had for lunch. He rested for several hours and then had severe sudden chest pain. So we'll just stop right here and say, if this happened to anybody now in their 30s, 40s, 50s, or 60s, whether they were the president of the United States or not, they'd get evaluated in the emergency room, probably hospitalized, but not our gentleman. His personal physician was called. This was after hours after he had this severe chest pain. He was seen 2 hours later, and his physician had seen him basically in the suite he was staying at in his hotel or wherever he was staying at the time, and gave him intranasal amyl nitrate, IV morphine, and papaverine. And I don't bring that up to talk about the drugs. Amyl nitrate and papaverine are vasodilators, so they open blood vessels. So not an unreasonable thing to do. And morphine we give to cardiac patients because not just for its pain relieving qualities, but it takes stress off the heart. But the fact that his physician gave him intravenous drugs in a hotel room, right? I mean, this is the president of the United States. You don't take him to a hospital. You're doing that in a hotel room. Or says I wrote stayed at home, but it was really in a hotel room. So 8 hours he stayed there. 8 hours later, had persistent chest pain. They finally bring an EKG in, and the EKG shows an acute anterolateral myocardial infarction. So what that is a big anterior heart attack. So anterolateral, that's the front part of the heart. The major artery, the left anterior descending artery is blocked, and it's causing damage to the entire front of the heart. This is a really serious situation. So finally, they decided after all this that we should hospitalize him. This is 24 hours after his initial symptoms. But we had to make him walk to his car on the way to the hospital to show that he was strong, to show that he was tough, right? We took a guy who was in the middle of having a heart attack, and we made him walk to his car. Oh, well, did anybody know who this is? Eisenhower, Dwight David Eisenhower, correct. So he got to the hospital. He was treated with oxygen, morphine, papaverine, atropine, heparin, and Coumadin. So, this is what we had at the time. Oxygen takes stress off the heart. Morphine we talked about. Papaverine is a vasodilator. Heparin and Coumadin are anticoagulants. They thin the blood. And this is what we did at the time. This is what we had. Atropine is interesting. Atropine speeds up the heart. Not sure what the benefit there would have been. Cardiologist called. I'm not sure. I would assume that the hospital in Denver had a cardiologist, but they called our friend Paul Dudley White, who flew across country to see him. His blood pressure was recorded as 115/65. His heart rate 90. That's all good. Friction rub was noted. So friction rub is an inflammation between the wall of the heart and the pericardium, which is a sac around the heart. And this is a common thing in people that are having a heart attack or have had a heart attack, to hear a friction rub, which means the inflammation of the heart has caused the pericardium, the sac around the heart, to rub against the heart. More importantly, EKGs showed premature atrial and ventricular contractions. So the reason that many people die while they're having a heart attack is that the suddenness of the heart attack leads to a rhythm disturbance. And so the heart goes into an abnormal rhythm, ventricular tachycardia, ventricular fibrillation, which can't support the blood pressure. And that's why the patient dies. And the main reason to hospitalize people immediately after a heart attack is to put them on a cardiac monitor and to make sure they don't go into ventricular tachycardia and ventricular fibrillation. So this is where Eisenhower was just very lucky, because he wasn't hospitalized for 24 hours. He certainly could have gone into ventricular tachycardia or fibrillation. Now, granted, there weren't defibrillators at the time, so I'm not sure how much more could have been done in the hospital than out, but that was where he was very lucky. He's having these atrial and ventricular contractions, but he never went into a rhythm that led to his death. Dr. White came, he diagnosed this as a moderate attack of coronary thrombosis. Basically what that means is a blood clot in one of the arteries that feeds the heart, the left anterior descending, and that blood clot leads to the death of a part of the heart, and that's what a heart attack is, a blood clot blocking off the circulation, leading to a death of that part of the heart. There was no significant change in therapy, because this is what we had at the time, bed rest. White came, he looked at things, he examined him, he said, yep, we're doing everything we can. He gave some press conferences, and then 24 hours later, he left. And this is Paul Dudley White with Eisenhower. So what was acute coronary syndrome like in 1955? And, 1955, not that long ago. Some of you may have been around in 1955. But the progress we've made in cardiac care since 1955 is really unbelievable. At the time, 30 to 40% of patients who reached the hospital died. Obviously, all of those that didn't reach the hospital died. And the reinfarction rate, the ones who had a repeat in the survivors was 100%. Everybody had another event because we had very little that we could do to prevent the second event. Bed rest, anticoagulation were the main treatments that we had. There were no cardiac care units, no defibrillators. That was 1962. Thrombolysis is where we go in and we break up the clot. We give a drug, a clot buster drug, to break up the clot. So that didn't happen until 1985, which is about the time I started in medicine. Angioplasties or stents, you've probably heard of that. Angioplasty is when you go in with a balloon and break up the clot. A stent is when you stick a stent in to open up the artery. So that's 1995. We had no antiplatelet agents. We had aspirin, but we didn't know it was an antiplatelet agent. And then the other drugs we used to prevent the second heart attack: beta blockers, statins, which are cholesterol medications, angiotensin blockers. These are things that everybody who had a cardiac event would get today. We had none of that stuff at the time. When Paul Dudley White gave a news conference after Eisenhower's heart attack, they asked him what the major cardiovascular risk factors were. And he said male sex, muscular build, type A personality, heredity, stress, diet, and exercise. So interesting, and this was the preeminent cardiologist in the country at the time, and that's what he said were the risk factors. And he said smoking was less important, which is interesting. Alcohol, and I don't know what he meant by religious and social customs, but this is what he said in his lecture. Non-medical ramifications in Eisenhower's case. The Dow Jones dropped 6% the day after the news of his heart attack. It was the largest decline since 1929. The lack of candor during Woodrow Wilson's illness affected the American people and the White House staff. And I guess meaning that Americans were skeptical about what they were being told. I wondered whether some of their skepticism wasn't from FDR, where everybody was telling him how healthy FDR was until the moment he died. But in order to change that, there were 11 press briefings the day after his heart attack, many more in the following days. Paul Dudley White, as I said, came, and he's displayed unique transparency in he talked to the American people about heart attacks and also about Eisenhower's specific case. He educated the press and the public. He reassured the public about the ability of one to resume normal activities after a heart attack, which was not something that people understood at that time. And the public must have been somewhat reassured because Eisenhower was reelected in 1956. Some of the medical aftermath for Eisenhower: he had a bowel obstruction 9 months after his heart attack. He was diagnosed with Crohn's disease. He had a bowel resection and a colostomy. The interesting part of that is, we are very averse to operating on people who have just had a cardiac event. No surgeon wants to go in and operate on somebody who's just had a cardiac event because the risk of a cardiac event during surgery is so high. And so I'd like to imagine what that surgeon was thinking when he had to open up the President of the United States and do a bowel resection colostomy after his heart attack, especially given the rudimentary stuff we had at the time. I'll bet you that surgeon was really nervous. Eisenhower had a stroke in 57, which affected his speech. Luckily, it was somewhat transient. Stroke and heart attack are basically the same disease. It's a blood clot. The stroke's a blood clot in the brain, and heart attack's a blood clot in the heart. And if we had some of the treatments that we have now, then hopefully that could have been avoided. Eisenhower had his next heart attack in 1965. He had a total of 7 heart attacks and 14 cardiac arrests between 55 and 69. He was one of the first patients who benefited from the use of the defibrillator. He was one of the first patients to receive Brutilium, which is an antiarrhythmic drug to prevent the arrhythmias that can happen after a heart attack. Now, interestingly, he was considered for use for the newly developed intra-aortic balloon pump, but the developer was worried that if he had a bad outcome, no one else would use their device. And so they actually refused to give it to him. So here's a case where the president doesn't get good medical care, which just blew me away. And then he had progressive cardiac decompensation, which led to his death. So conclusions from my read of the medicine history literature. Washington could definitely have lived through his illness even in 1799. I really think if Dr. Dick had been listened to, Washington would have made it a lot longer. FDR could have lived a much longer, healthier life if we just understood high blood pressure. Eisenhower was lucky to some extent in spite of his medical care. He was lucky he didn't have an arrhythmia, especially as he was walking from his hotel to his hospital. I would have hated to see those press photos. And all of these cases, and many, many more, have affected the course of history. I didn't talk about Woodrow Wilson because it's such a complicated case, but it's a fascinating case of the intersection of medicine and history. Wilson had a huge stroke. He was incapacitated for almost a year. And Edith Wilson, who received exactly 0 votes for president, was essentially our president for a long period of time. King George VI, as Queen Elizabeth's father, from what I've read, he was diagnosed with lung cancer. Nobody told the British people. To some extent, nobody told him. They removed part of his lung, but they did it in the palace, not in the hospital. So, crazy stuff happens to people, people's medical care just because they're prominent. And sometimes it's not good stuff. The modern era of medicine is very, very recent. When I came into medicine in the late 80s, early 90s, much of what we did was based on expert opinion. And now the majority of what we do is based on clinical trials. And that's been a huge change in just 30 years. But if you think about the case, Eisenhower's case and what's happened with heart disease, we had people dying in their 40s and 50s all the time back then. And we've had much less of that now because of the huge forward movement in medicine in the last 30, 40 years. There are milestones of progress over many years that have moved us forward. The understanding of anatomy, the control of pain, our ability to prevent infection, just hand washing. The Flexner Report. If you're not familiar with the Flexner Report, it came out in the early 20th century. And basically it said our medical schools are a joke. There are no standards in our medical schools. We have some medical schools that are doing almost no medical teaching. And the Flexner Report developed standards for medical schools, and it made medicine a much more rigorous profession. As I said earlier, randomized controlled trials and evidence-based medicine have been extremely important in the creation of modern medicine. So if you just take high blood pressure, for example, when I came into medicine, there was an idea that it was acceptable for older people to have higher levels of blood pressure, and that your systolic blood pressure, your top number, should be less than 100 plus your age. So basically, if you're 50, it should be 150 or less. If you're 80, it should be 180 or less. Absolutely wrong, completely wrong. And it wasn't based on anything. It was expert opinion. Once we started doing controlled trials, evidence-based medicine, we realized that we should keep everyone's blood pressure lower, and being older did not mean you should have a higher blood pressure. So just as an example of how we've moved forward because of evidence. There have been many instances of moving backward in the history of medicine, and we should be diligent in attempting to prevent this. And, someone might say, well, gosh, we have evidence-based medicine now. We have all these great medical schools now. How would we ever move backward? Hydroxychloroquine, ivermectin, right? What was that? 2 years ago, 3 years ago? This is something we need to keep our eye on the ball. This is a great book, Empire of the Scalpel, The History of Surgery by Ira Rutko. Ira Rutko is a professor. I think he's at UPenn. The history of surgery, up until recently, is the history of medicine. And he basically goes through the 4 important things that move us forward: the understanding of anatomy, the understanding of circulation, the understanding of preventing infection, and pain control. And it's a great read, very interesting. I would recommend it to you. These are my references, basically the books and articles that I got my information from, and these are the photo references. And I'm happy to take any comments or questions.
Thank you so much, Dr. Soboeiro. We have a couple of questions, I think, in the audience. If you could please raise your hand, we're going to bring a mic around. And then we've got some questions from our folks over Zoom as well.
Oh, hello, hello. About your comment about dissection and going way back. Leonardo da Vinci did many dissections. Michelangelo did many dissections, and of course Vesalius did his famous dissections, and that was all in that time period that you were talking about. I don't think it was there was. I think you misspoke when you said that it was the church that banned dissection.
Okay.
I think it was more, there was no refrigeration, and it was really kind of a disgusting thing to be doing.
Okay.
You know?
Most of the people you mentioned, though, wasn't that 1400s, 1500s?
Yes.
Okay. So I think I had read that it was over 1,000 years that the church prevented it, and then that it started to come in at that point. But I may have had those years wrong. But Rutkow makes the point in his book that that the inability to do necropsy for a long period of time held us back.
Oh, of course,
Yeah.
of course. And also
But-
that everyone was so enamored with Galen that they refused to put down some of his thoughts.
Right, right. Thank you for that.
I wonder what your lecture will be like in regard to Reagan being shot and Trump having COVID, because those are two situations that we probably don't really know the whole story.
Yeah, I mean, I know a little bit about those two, and I think, you know, I think looking at those cases, we've certainly gotten away from, you know, treating officials differently. You know, I think Reagan got very quick and good medical care. I think that you know, Trump got very quick and good medical care for COVID. Yeah, there are all kinds of cases I think you could talk about how our presidents were treated, you know, good and bad. Yeah.
So thank you for your speech. And looking forward, I wonder if you could make a prediction, say 100 years from now, 500 years from now, how are we going to look back that we're not bloodletting through chemotherapy or amputation or a number of things that we're practicing right now? Is there one area that you see, you know, I can't believe that we were killing white blood cells with chemotherapy? Or can you speak to that?
Ah, gosh, I
Your
mean,
forecast?
yeah, I think that's a tough one. I mean, I think it might not even be 500 years, it might be 20 years. Because, you know, that, like I said, there are things that we did while I was in medicine that we don't do anymore. There are things we're coming up with all the time. I don't know if it's, you know, a specific area, but I think, you know, you brought up chemotherapy. I think, you know, there's so much research right now to be so much more targeted in what we do with cancer. And chemotherapy is like the analogy I made earlier, you know, the sledgehammer on the nut, right? I mean, chemotherapy, you're attacking the entire body with these toxic substances. And we have these very specific, you know, antibodies, autoantibodies that we can attack specific cancer cells now. So yeah, I think your analogy is true. We'll see.
Okay, we've got a question from the chat. Phyllis asks, why do you think Doctors Craik and Brown attending George Washington decided against Dr. Dick's suggestion of a tracheotomy?
That's a good question. And I actually have read everything I could about that. And I never got any real explanation other than, you know, the older doctors had been with Washington longer. And they were skeptical of, you know, the young people and what they were recommending, skeptical of new things. That's all I've ever gotten. But I'll also throw in that I went to Mount Vernon. My son was actually a docent at Mount Vernon one summer. And I went to Washington's bedroom, and I had recently read the article in New England Journal of Medicine about Washington's death. And I mentioned to the docent that was up there about the 3 physicians and all of that. And she said, that's completely untrue. And I said, well, I read it in the New England Journal of Medicine. And she said, well, it's wrong. And if you persist in talking about it, you're going to have to leave.
During the FDR portion, I think you mentioned the ability to reverse some of the damage that has been created by hypertension. I'd be interested in hearing your thoughts on where we sit with that now and what's probably the areas that we'll see some advancements there, retinal and renal in particular. Regarding the Washington portion, I wonder what would have happened with this country if he never got out of the Battle of Fort Necessity, which was a close call for him. And then third, if I could, what are your thoughts on hypotension and when is that a problem?
Okay. So 1 and 2, I'm going to be better at than Fort Necessity. So in general, if somebody has elevated blood pressure, you got to think of it like plumbing. Okay. The heart's the pump and it's pumping against this obstructed pipe, right? And you open up that obstructed pipe and you relieve the pressure and you make it easier for the pump. So we know people who have heart failure and enlarged hearts, if you lower the blood pressure and you take that stress off, over time, those people with enlarged hearts and heart failure, the heart can actually start functioning normally again. Now, not all of them, sometimes they're too far gone, but by taking the stress off and letting the pump function normally, oftentimes you can get those end organs functioning back normally again. And that's true also with the kidney, because the same thing's happening in the kidney. And it's true in the retina, like you said, because so that's really the underlying part. And I'll take on the hypotension part with that. There is a linear relationship between mortality and blood pressure, and it goes down to about 100/50. And one professor that I had back in training with cardiologist, and this was when they started doing these stents and things, and somebody raised their hand in the audience. They said, Dr. Fuster, what's the best blood pressure after one of your procedures? And he said, 2 points above passing out. The point is the lowest blood pressure that the patient tolerates is probably the healthiest for the organs. Now, obviously, you do not want to get blood pressure down to the point where people are falling and breaking hips and passing out and all of those things. So that's some of the art of medicine, especially as patients get older, to manage blood pressure as safely as you can get it without causing low blood pressure.
Hypotension issue of my family.
Yeah.
I've been prescribed dietary salt. What? Doctor told you to give you more salt.
Yeah. And you're right, it can be an issue too, but in treating high blood pressure, obviously you're avoiding hypotension, but you're trying to get as low as you can. Now, Fort Necessity, I don't know anything about. Okay.
We have one more question from the chat. Any other presidential medical case studies that you've checked out? And if so, do you have a favorite one?
Well, I think my favorite one is Washington. I think that's been the most interesting to me. I think many presidents have had interesting medical histories. William Henry Harrison, who, died of pneumonia that he apparently got at his inauguration. I think Wilson is a really interesting case, and maybe I'll develop a lecture and just talk about Wilson because the implications of Wilson are interesting. And I'm gonna preview what my next interest is, and I talked to Stacy about this earlier. There was a committee in the late 70s that looked at the 25th Amendment and the fact that the 25th Amendment should be updated because it was written in the 1920s and before any of these things, right? And so it needs to be updated for the medical care that we provide today. But it's a political football, and they tried to look at it in the late 70s and early 80s, and even though there was no specific concern about who was in office at the time, which was Carter, Congress didn't do anything with it. And the person who spearheaded that look at the 25th Amendment was a North Carolinian, was a professor of medicine here in North Carolina. So I think that's going to be my next talk if they'll let me give it, about the 25th Amendment and North Carolina and how that history went.
Thanks, Mike. Lovely talk. I just a quick question regarding the Washington thing. You said tracheotomies had been done throughout history from time to time, sometimes successfully. I'd like you just to discuss the tracheotomy and possibility of infection leading to other complications, possibly death.
You mean infection once you do a tracheotomy?
Once you do the tracheotomy.
I mean, I don't know, I don't know those numbers and those rates. I will say that, tracheotomies are done all the time out in the field emergently, right? And, it's just a little skin and then it's the cartilage of the trachea. So, I mean, sure, it could get infected, but I mean, I think that's a pretty minimal concern, compared to opening up somebody's airway and acutely and letting them breathe when they have airway obstruction. I mean, I think a lot of these things that were reported in medicine in antiquity happened, but they didn't always have, good outcomes. But I think the biggest thing was, medical information wasn't shared. So, they successfully did a tracheotomy in 1540. But what was the way of sharing medical information at the time? Nothing like today. Rutkow starts his book by talking about how in antiquity there were skulls where clearly someone had done neurosurgery, someone had done a brain operation, someone had cut a hole, and the patient had lived, right? They knew because it had healed, right? And so this is a person who had some type of brain operation and then lived. But of course, nobody knows what happened, but so stuff happened years ago that people did, and sometimes it was successful. There was just not a moving forward of information. So,
Thank you.
yeah.
We have time for one more question.
So you were talking about how the changes in medicine have helped everyone and not just presidents. But I want to also point out, and I know you know this and everybody probably knows it, but our social milieu has a lot to do with our treatment. So not that long ago, North Carolina thought it was a good idea to participate in the eugenics of sterilizing women who were seen as undesirable in some way, which mostly I think was based on race and class and perhaps disability. But even now, I don't remember how long ago I read this, a couple of years ago, the people who get the least amount of pain medicine in hospitals are Black women.
Mm-hmm.
So lots has happened on all those fronts, right? But continues to need to happen. And thankfully, we finally have a little bit of expansion in Medicaid in North Carolina for working age people, but there's way more to go. So I guess I'm wondering, what is your kind of vision for the near future in some of those places?
I mean, I think you bring up an important point, which is we've had all kinds of movement forward in medicine, but unfortunately, we still don't provide medical care to all of our citizens, and we need to do that. Medicaid expansion in North Carolina will certainly move us forward, but it doesn't get medical care provided to all our citizens. I think it's a travesty when someone dies because or someone gets sick because they don't have access to medications or medical care. And you also bring up, I mean, we gave syphilis to people in the 20th century, that's just astounding that we did that. The modern medicine is very recent, and we still have a long way to go in terms of providing good care to every single person. Absolutely.
Thank you.
Thank you very much.
Thank you so much, Dr. Soboeiro, for this talk today. And thank you all those who joined online. We hope to see our next adult program, History and Highballs, the history of the ice in your drink, where we'll deep dive into the origins of ice for personal use here in America. That's tomorrow evening over Zoom starting at 7 p.m.